Hi, I'm Tilak Shah from Cleveland Clinic, Florida. I'm going to talk about a recently published manuscript in GIE titled Top Tips for Malignant Esophageal Obstruction. Esophageal obstruction by cancer is not a rare problem, and although there are several possible interventions, knowing exactly when to apply each can be confusing. In this paper, I tried to summarize my approach to malignant esophageal obstruction. With regards to which modality to use, at initial diagnosis, esophageal dilation is the most practical and efficient method to palliate dysphagia. The diameter of the gastroscope can be used as a gauge for luminal diameter. The rule of threes is a prudent rule of thumb and recommends passing no more than 3 dilators per session once moderate to severe stenosis is encountered. In patients with newly diagnosed, locally advanced esophageal cancer, spray cryotherapy improves dysphagia and improves quality of life when administered before neoadjuvant therapy. I usually try to avoid stents in this setting because they may increase grade 3 toxicity and reduce survival. Cryotherapy is also useful in patients with inoperable cancer who have good performance status and a luminal diameter greater than or equal to 9 millimeters. Where I find stents to be useful are in patients with inoperable cancer who have a poor performance status or a luminal diameter less than 9 millimeters. To optimize administration of spray cryotherapy, I typically spray for 30 seconds after a bed of frost has formed. Paint a hemicircumference with cryogen rather than spraying one spot to minimize the risk of nitrogen gas dissecting through the muscularis propria. If the lumen diameter is too small to accommodate a decompression tube and a gastroscope, consider using an ultraskim gastroscope. When it comes to stenting, fully covered metal stents are most frequently used in clinical practice. If luminal diameter is close to 9 millimeters or larger, then larger diameter 23 millimeter stents can reduce migration risk. Conversely, in patients with a very small lumen, a smaller diameter stent can reduce chest pain related to stent placement. When possible, I prefer to mark the proximal and distal ends of the tumor on fluoroscopy using paper clips taped to the patient's skin. The fully deployed stent is ideally 1 to 2 centimeters proximal and distal to the tumor. If the tumor is well above to the gastroesophageal junction, try to avoid deploying the distal end of the stent in the stomach to reduce stent-related GERD. I place all patients on a PPI after stent placement to reduce GERD. Chest pain is common and is usually managed with non-opiate analgesics like liquid Tylenol. Migration is a common problem with fully covered esophageal metal stents. Endoscopic suturing or an over-the-scope clip with a rounded design can reduce migration risk. When stent removal is necessary, I prefer to use a double-channel gastroscope, which allows me to grasp the opposite ends of the proximal portion with 2 rat tooth forceps. Another approach for difficult removal is to grasp the distal end and pull the stent into the stomach or remove it like a sock. Another technique is to place an overlapping stent for a couple of weeks before removing both, the so-called stent-in-stent approach. I hope these tips will be useful to endoscopists when they take care of their patients with malignant esophageal obstruction. Thank you.